So we are going to start the central nervous system, and we start with the lowermost part, which is called spinal cord. And you know, spinal cord is located within the vertebral column and within the vertebral canal there. For the spinal cord, we use several synonyms. The Latin synonym is medulla spinalis, as we can find it inside the spine, and the Greek synonym is called myelon, and then the inflammation is myelitis. Yeah, and it's located inside vertebral canal, and this is the external shape, and we will follow a general scheme to describe the external features. Then we go to describe the internal features, the nuclei, that means the gray matter, and then the white matter, the tracts, and then some specialties. As you can see, the spinal cord is quite easy concerning the external features. They are spinal nerves leaving the spinal cord in a form of roots, anterior and posterior root. And then there are some grooves on the surface, yeah, and that is all what we can see. Just to review shortly embryology, we know that the central nervous system is derived from neural tube, yeah, and we can see neural tube here on the left upper side, and the neural tube consists of two parts, and I will highlight it, yeah. So this is the part which we call basal plate, yeah, and it's motor, and this part which we call alar plate, and the alar plate is sensory. Yeah, that's why the ventral area, the anterior root is motor, the dorsal root is sensory. Yeah. The structure here is neural crest, and the neural crest then forms the ganglion, which is visible here, the spinal ganglion. Yeah. But now we are going to talk about the spinal cord, and we will see this arrangement here in spinal cord. That means the anterior horns are motor from basal plate, the posterior horns are sensory from alar plate, and the lateral horns are half motor, half sensory, but they are sympathetic and parasympathetic, so they are visceromotor and viscerosensory. Yeah, so this is the autonomic area, and the visceromotor fibers run like this, and the viscerosensory then like this. Oh. Then you can understand the functional division of spinal cord, and we can move to further slide. Here, this slide shows you that spinal cord grows more slowly than vertebral column. Yeah. Here in an early fetus, what you can see is that the spinal cord reaches as far as the caudal end of vertebral column. But then in 24 weeks, it's already at the level of C1, which is not so important for us. But what is important for us is where it is at, during adulthood and where it is after the delivery. Yeah, so after the delivery, the level is L3, but then finally the level is L1, or the intervertebral plate L1, L2. What continues here is called Cauda equina. Yeah, you know what? It's called Cauda equina, and it is encompassed by a continuation of the meninges. Yeah? So we have three meninges, and the meninges continue also down, and they terminate approximately at the level of C2 Yeah, and here is just a small rest which is attached to coccygeal vertebra. So this space then it contains the Cauda equina, and this, which is a real remnant of spinal cord, but it's only a glial structure without function, and it's called filum terminale, like terminal thread. Yeah, filum terminale. No function, but it is there. Yeah, you can see then on a specimen. So this is very important. Where is the terminal end? This space is filled with Cauda equina and cerebrospinal fluid in this, which we call a lumbar cistern, and we can perform puncture here. We will talk about the puncture later. So we can continue. If you have questions, you can of course ask. Yeah. So for the spinal cord as a whole, it is segmented as the somites have been segmented into vertebral bodies and intervertebral discs, and then myotomes. And of course we have this segmentation, and the segmentation is similar to segmentation of the spinal nerve. So we have 8 cervical, because the first one leaves the spinal cord between occipital bone and atlas. We have 12 thoracic, 5 lumbar, 5 sacral, similar to number of vertebrae, and only 1 coccygeal, as it is the very end, and coccygeal nerve innervates only skin overlying the coccyx. Okay? So what is the function of the spinal cord? It's a seat of reflexes. Yeah, so the reflex come in, ascending limb, then it's synapse and goes back, descending limb. Yeah, so it's a seat of reflexes. Yeah, it gets information, and if the information is important, it is sent up to CNS. Yeah, so it serves as a computer with input and output, and the output is down. If you would like to move, you send the information down and you move. Yeah. So it's a seat of reflexes. It contains nuclei and it contains tracts which ascend and descend. So that's just the general information. Now let's go to the external morphology. So we have already talked about the anterior root and the posterior root, which originates as rootlets, yeah, which you can see here. And on the posterior root is a spinal ganglion. That's very easy. Now let's continue with the other features, which are the grooves. Before the grooves, of course, do not forget the contents of the anterior and posterior root. Yeah, anterior is motor, posterior is sensory. Then it forms the trunk of the spinal nerve and sends two communicating branches, white and gray, and the meningeal branch to supply meninges and their vessels. Yeah, and it continues for the epaxial muscles and the skin, posterior branch, and epaxial muscles and skin, anterior branch. Yeah, I think there's no discussion about that. So what is the arbitrary beginning of spinal cord? Spinal cord is a fluent continuation of brain stem of medulla oblongata. Yeah, so we have decided to have an arbitrary border, and you can see it externally at the level of foramen magnum. Yeah, below foramen magnum there's an exit of first cervical spinal nerve, and on the anterior surface you can see a decussation of the main descending voluntary motor tract, which is called pyramidal tract. Yeah? So we can see the decussation of the pyramidal tract. So that's the beginning. The end we have already named. It's called filum terminale. It's just the glial termination with no function. And we know that the caudal border is at the level of L1. There are two enlarged areas. In these two enlarged areas, you find alpha motor neurons for limb muscles. So we have in a cervical area, and this area approximately matches the roots for brachial plexus. These are roots for brachial plexus, and that's why the area is enlarged. We call it intumescentia, which means, if you translate it, a swallowing, but it's not a swollen part, it's enlarged part, yeah? But this ugly term is used, intumescentia. And then for lumbosacral plexus, it is lumbosacral plexus, lumbar and sacral plexus, they all together, they are T12 to S4. But S2, S4 is pudendal nerve, so it's not so big. So the lumbosacral area is T12 to L4, yeah, the intumescentia. So it a bit matches the plexuses, but not exactly. And then we have the grooves. As you can see, majority of them are called grooves. Only ventrally is fissure because it's very deep, yeah. So the anterior median fissure is deep. On the contrary, posterior median groove is very shallow. Yeah. In both of them, there's a pia mater, so the deepest Meninges, it's running into, yeah. As the ventral one is deep, the pia just gets in. As the posterior one is shallow, then the pia gets into the spinal cord matter, yeah, inside, and forms a septum, which is not visible externally, but is visible on cross section. I'll show you on a figure in a minute, yeah. And then we have another grooves on the side, yeah, at the level of the anterior and posterior roots. So we call them anterolateral and posterolateral. And then the last one, which is called posterior intermediate. I will show you on a figure, all of them. So if you see it here, anterior median fissure is very deep. Yeah. Then the anterior root appears in the anterolateral groove, which is here. The pia mater gets into the anterior median fissure. So that's from the anterior point of view. From the posterior point of view, there's a shallow posterior median groove, but there's a septum which continues up to here. So then the white and gray matter are quite divided, and the only area where they communicate is in the middle. Yeah. So it's a shallow posterior median groove and continuing PL posterior median septum. Then you can see this groove, which is the posterolateral groove where the posterior root emerges. And then this very shallow groove. This very shallow groove is called intermediate posterior. Posterior because it's dorsally, intermediate as it's between these two fascicles. And these two fascicles are called according to their shape. The medial one is called gracile, when gracile means a slim. Yeah? So it's called fasciculus gracilis, slim one. Thinner one. This is the thicker one. And as it goes up to the brain stem, it is enlarged. Yeah? So it looks like a wedge. So it's wedge shaped. And in Latin, we call it cuneatus. Cuneus is wedge. Yeah? So these two fascicles are called gracile and cuneate, and in between you find the intermediate posterior groove. Okay, there's a question. How is it that the first branch of the spinal cord after foramen magnum is C1 and not C0? I don't know. It was decided like that. Yeah, it was decided that it's called C1. So that's all for this. And when we move here, we can see the very end. As we call it, this is filum terminale, yeah, the termination. The filum terminale consists of different parts, and the spinal cord part, the glial part without function, is called spinal part of filum terminale, yeah, no function. So it is not much important. But then what is important, this area is called a cone, medullary cone, conus medullaris, yeah, according to the shape, as it's a cone upside down. And it's at the level of L1 and at the level of the intervertebral disc L1, L2. And you can see the segments here S3, S5. So in case we have a problem here, then these segments are affected, and we will talk about the syndrome of conus medullaris then. And the area above is, so this is conus medullaris or cone, and this is called epicone. Epi, above. So epicone is a level above, so vertebra T12 and the intervertebral disc T12L1. And it contains another 3 segments, yeah, so all the time it's 3 segments. And you can see that these 3 segments approximately matches the sciatic nerve, yeah, sciatic nerve is L4, S2. So the problems in compression of epiconus will be mainly in the area of sciatic nerve and in the area of leg and foot. And of course, then the continuation is Cauda equina. Yeah. So please, these 2 terms are very important for neurology, and we will talk about their lesions, yeah, a bit later. So conus medullaris, medullary cone, and epiconus, the area above that. All the time 3 segments. So we can go on. So when you have a fracture of the vertebral column, you have to know which segments are affected. As the growth of spinal cord is slower and spinal cord is shorter, it means that the vertebrae do not match the segments. They match them at the upper cervical vertebral column. Yeah, they match it. So if you have axis, inside axis, you can find segment C2. But if you go down to C7, you have to add 1. So at the level of C7, the segment will be T1. Yeah. At the level of vertebra C7, inside is a segment T1. If you go down, you have to add 2 and you have to add 3. So at the level of T2 vertebra, the segment will be T4. At the level of T7 vertebra, the segment will be +3, T10. So if you have, for example, compression at the level of T7, you can see problems in the intercostal nerves down to 10th intercostal nerve. So when we go down at the vertebra L1, we have the conus medullaris, segments S3, S5. Yes, we have talked about this just a minute ago. At the level 1 vertebra above, we have the epiconus. So segments L5 to S2, which nearly matches the sciatic nerve. Yeah, and another level above, vertebra T10 to T12. We have here segments L1 to L4, 5. So this is very important for clinics. If you have problems in the level of some vertebra, you can derive which segments will be harmed, and then you can derive which peripheral nerves will be injured, and you can see the symptoms. Yeah. So this is called the rule of Chipold, a French guy, Chipold. So please remember this vertebromedullary topography, which is called the Chipold's rule. Yeah. Okay. Next one. Next one, what we need is where to perform lumbar puncture and which structures we go through. Yeah. So let's look at this. This is what you already know from the vertebral column when we studied it. Yeah. We have the spinal cord, which is from here to here. And then we have some structures which are around 3 meninges and then some arteries and veins. So I go back to here and we can see layer by layer how the vertebral canal looks like when we get from outside inside. Yes, so this is from outside inside. So you have the bone, and the bone is covered with periosteum, and the periosteum here has a clinical name, and it's called endorachis. Endo inside, and rachos is vertebral column in Greek. Yeah. Then rachitis is an inflammation of the vertebral column. Yeah, of the soft tissues of the vertebral column mainly. So endorachis is the periosteum. Then you have the epidural space. The epidural space does not exist in the brain. And if you have epidural bleeding, can you tell me which vessel is ruptured during epidural bleeding? Can you write the answer into the group chat, please? If you have epidural bleeding inside the skull, which vessels can be harmed? We know that the shape of epidural bleeding is lens-shaped, and the right answer, Julia, is middle meningeal artery. Perfect. But the epidural space exists in spinal, in vertebral column, as we can see here. It exists, yeah. And it contains these venous plexuses, and you know them as the internal vertebral venous plexuses, anterior and posterior. Yeah. So the space here is filled with venous plexuses and loose connective tissue. Yeah. So that's the difference between vertebral column and a skull. So we have an epidural space. Then we have, of course, the dura mater. The dura mater looks like this. It's a sac sending at each level a sleeve outside, yeah, and on the other side like this. And I will terminate it here at the very end. So this we call the sac of dura mater. It then continues here into the opening. The opening, of course, we call intervertebral foramen. And the dura mater, as it's a cover, it fuses here with the covers of the nerves. So, what are the covers of the nerves? Do you know the name of the cover, outside cover of the nerve? Please write me. Epineurium, Katarina, perfect. So the dura mater, which is red, fuses with epineurium, which is green, and fuses with periosteum, which is blue. Yeah, and this fixes the whole dura mater inside the vertebral column. Yeah, and it's of course fixed here down to periosteum as well. Yeah, as the filum terminale. So that's the dura mater. Now arachnoidea. Arachnoidea is firmly attached to dura mater. So there is no space here, yeah, no subdural space. You may remember the subdural bleeding. Do you know from which structures the subdural bleeding happens? The subdural bleeding inside the skull, of course. The shape of the subdural bleeding is a crescent-shaped or moon-shaped, and it's not from venosinuses, but it's close. When this is the sinus, it comes from veins, which comes from the surface of brain. So these are superficial veins, yeah. And if there's a hit, then they can be ruptured here. They can cause the subdural bleeding. So the answer is terminal portions of superficial cerebral veins. Yeah. So that's for subdural bleeding in the skull. As this space does not exist, this space exists neither in the skull nor in the vertebral column, and there is no subdural bleeding in the vertebral column. So there is no such space here, yeah, and we can skip it. Then we have the subarachnoidal space. It contains, what does it contain, the subarachnoidal space? Give me the answer, please. What does the subarachnoidal space, both in the skull and in the vertebral column, contains? No idea. No one. Cerebrospinal fluid. Perfect, Zahra. Perfect. Yeah, cerebrospinal fluid. And if there's a bleeding, which vessels cause bleeding into subarachnoidal space? Please write me the answer. And in between, I can tell you that if the spinal, I will draw the spinal cord in. Yeah. Like the spinal cord is here. Yeah, it gives the nerves, of course. It continues here as the filum terminale. So you don't know the answer, which vessels cause bleeding into subarachnoidal space? The answer is cerebral arteries of Willis circle. Yeah. So these can cause subarachnoidal bleeding. And then the subarachnoidal space here down. Can you use a color, another color? So this space here down is called lumbar cistern. Yeah. And lumbar cistern is filled only with Cauda equina. And that's the space below the level of C1. Sorry, below the level of L1. Yeah, so this is the space where the spinal cord does not reach in adult, and it's filled with Cauda equina, filum terminale, and cerebrospinal fluid. And we call it lumbar cistern. Then the other and the last meninx is the spinal pia mater, and it covers the medulla spinalis. Yeah, it covers the medulla spinalis totally. So it occupies its surface. And then it's medulla spinalis. Denticulate ligament I will show you on a figure and explain. So now we know all the layers and spaces, and in clinics we can use them. So in the subarachnoidal space, and especially here in the lumbar cistern, we perform a lumbar puncture. And the lumbar puncture serves to collect cerebrospinal fluid, yeah, for examination. Or we can administer here some medicaments, yeah, usually medicaments against cancer or against pain, chronic pain. And during operation, we can administer here anesthesia, so-called spinal anesthesia. So you have three reasons Why? To open this space. Yeah, either you get the CSF out or you put inside anesthesia, which is just a short one during operation, or a long one anesthesia, so you administer medicaments against chronic pain. Yeah. So that's the lumbar puncture. Then we can have anesthesia, yeah, during operation, which is not applied inside this space, because this the cerebrospinal fluid takes it farther, so it's more extensive. If you would like to have it or locally, you just put it into epidural space. Yeah, and the epidural space we find the roots of the spinal nerve. So the epidural anesthesia is used if you would like to block the area of this level. And then, of course, you can get directly inside the spinal cord, and we use this as an electric stimulation in chronic pain. Yeah, if the other approaches do not work, then you can put a needle inside a special area in posterior horn. You can stimulate there, and it can suppress the pain. In previous times, the spinal cord was even cut. Part of it used to be cut during these several severe pains. Yeah, now we do not cut it anymore, we just stimulate it. So now you understand that it is important to know the layers, and we can move to some figures. So here you can see the lumbar puncture. Yeah, this is the Cauda equina and filum terminale all together. And if you perform the puncture, you go in the midline between two spinous processes, and you have to go through the epaxial, that means deep back muscles, and you have to puncture two hard structures. One hard structure is this, which is dura mater, and you can hear it like a crack. And the first tough structure, also which you can feel as a crack, so you need two cracks to get inside here for the lumbar puncture, or only one crack to get here into the epidural space to perform the anesthesia. Tell me the name of this first structure. Which tough connective tissue structures is here between the spinous processes, between the arches of the vertebra? Any idea? Which connective tissue, which ligament is in between arches of vertebrae? Interspinous ligaments are here, yes, but they are, if you look at it, they are like this, but then we have something which is large. And it's like a curtain in a frontal line between the arches, and we call them ligamenta flava, the yellow ligaments. Yeah, I hope you remember them. Yellow ligaments, ligamenta flava. So these two structures has to be pierced. Yeah, ligamenta flava and the dura mater. We have talked about this, about the supracranial anesthesia or spinal anesthesia. So you administer it into cerebrospinal fluid space, or epidural anesthesia into epidural space. And we have talked about this. So what is nice here, nicely visible, are also the vessels. You can see vessels here. Anterior spinal artery, which is on the surface of the anterior median fissure, and posterior surface arteries, posterior spinal arteries, which are usually paired. Some of them run in the midline, but majority of them runs along the posterolateral groove where the posterior root emerges. And they supply the spinal cord, and they supply it like this. So this is the border. So you can see that the posterior arteries, which are larger in number, usually 2, 3, or 4, supply only 1/3, posterior 1/3. And the anterior spinal artery, which is alone, solitary, supplies anterior 2/3. So it's more important, clinically much more important for the spinal cord. Yes? Okay. So another figure showing you where we can put, of course, not at the level of the cervical vertebra, as you can see here, but this is the area for epidural anesthesia, and this is the area for spinal or subdural anesthesia and for lumbar puncture. Denticulate ligaments. What is a denticulate ligament? That's a very fine, soft structure, which I can highlight here. And it's a structure which is inside the subarachnoidal space, and it holds the spinal cord attached to the arachnoidea and dura mater. Yeah. So we have the spinal cord. I'm sorry for that. We have the spinal cord. Then you have the denticulate ligament. Oh, sorry. Again, make it nicer. Spinal cord, a denticulate ligament, and a dural sac, and a vertebral canal. And the body is here. So this is the body. So denticulate ligament, if I highlight here, is a structure which keeps the spinal cord, or holds the spinal cord inside the dural sac, so it does not move, yeah, to the sides. Yeah, and as I said, it's this structure which looks like teeth of a saw. Yeah, so you can see the individual teeth of a saw, and in the spaces between the roots of the spinal nerves pass. So that's the denticulate ligament. And we have to talk about the vertebral canal, and this is the content just to summarize, so you can then read it during study. And before we get in, the blood supply. Now you already know all the arteries. So you know that there is the anterior spinal artery, and there are some posterior spinal arteries. And you can see that there are 2 to 4 of them. Yeah? And you can see that they supply only the posterior 1/3. So how they are fed? We know that the anterior spinal artery is a branch of the vertebral artery. Yeah, right and left, short paired communication forms the anterior spinal artery. And if you look here, you can see how it continues down, yeah, here, and supplies the spinal cord. But it is not much reasonable to send the blood to the head and then back down here to lumbar area. So there are, of course, some smaller feeding arteries. Yeah? And we call them spinal branches, yeah, which are transverse. You can see such a spinal branch here. The spinal branch divides into anterior and posterior radicular artery, yeah, as it follows the anterior and posterior root. And then it comes and supplies the anterior and posterior spinal artery. So the spinal nerves are transverse branches, which then feeds the longitudinal branches, which are called anterior and posterior spinal arteries. Yes. So what you can see is that around there can be such a vascular annuli, and they are called vasocoronae, yeah, like a crown of vessel crown. So these rings are around, but they are not very thick. They are quite thin, yeah, but they exist. And then they supply the white and gray matter from ventrally. You can see this artery. So from the anterior spinal cord, the artery gets into the anterior median fissure and supplies the anterior 2/3, and it's called sulcocommissural, as it goes into the groove. Even it's a fissure, but it goes here, sulco, and commissural, that it reads the commissures. I will show you then that the commissures are this area. Yeah, so that's why the artery is called sulcocommissural. And then from these vasocoronae, there are very small branches, which we call peripheric arteries. Yeah, peripheric arteries, and they supply mainly the white matter on the surface. So, do you have a question to that? So this is a general arrangement. And now, which vessels sends the spinal branches? So in the cervical area, it's mainly vertebral artery, but also the two deep arteries which supply the deep cervical muscles, yeah, the scalene muscles, longus colli, longus capitis, and it's a deep cervical artery and ascending cervical artery. At the level of thoracic and lumbar vertebrae, it's easy. Posterior intercostal, which are branches of aorta and branches of supreme intercostal artery, and lumbar branches. In the area of sacral bone, lateral sacral arteries. And in the lumbosacral transition, iliolumbar artery and its lumbar branch. Yeah? So these all supply the spinal cord. Of course, these supply not spinal cord, but they supply Cauda, Equina, yeah, as the spinal cord terminates at the level of L1. So that's a nice general scheme, but the truth is that only some of them are larger. If they are larger, they are in clinics called radicular arteries, yeah? And the number of the larger one is quite reduced, and it's less than 10. And usually the largest one we find at the level of diaphragm, and we call it as its big one, great radicular artery, and it has been described by Adamkiewicz, who was a Polish anatomist. Yeah? So you can see the artery here. It's usually at the level of T12, L1, approximately here, and so it supplies the caudal 1/3. Yes. And we can see the Adamkiewicz here, yeah, and the artery at the level of T12, L1, sometimes higher, sometimes lower, yeah, and you can see that it's an artery which comes either from the posterior intercostal or lumbar artery to supply the spinal cord. What you can see here is the area of abdominal aorta. This can suffer from aneurysm. Yeah? If you replace the aneurysm with prosthesis, yeah, then the prosthesis has an prefabricated openings for celiac trunk and supramesenteric artery and the renal arteries. So then the vital organs are supplied. But you have to also put in to the prosthesis this small artery. Yeah, that means the intercostal lumbar artery. If you do not do it, then this part of the spinal cord is dead, is ischemic, necrotic, and dead. And what will happen? A paraplegia. That means a total palsy of lower limbs. Yeah? So you will save the life of the patient, but he will be on a wheelchair. So to prevent this, you have to know it. and you have to perform an angiography before the procedure. So you can see here, this is a celiac trunk, and behind the celiac trunk you can see here, this is the intercostal posterior artery, and this is the anterior spinal artery supplying the spinal cord. So you have to find the artery, fix the level, and then during the operation you have to think about this artery. Yeah, very important in clinics. So please remember the great radicular artery of Adamkiewicz. Yeah, at the level between like T12 to T9 to T12, sometimes to L1. Yeah, very important. As for the veins, it's very easy. Yeah, the veins are similar to the arteries. There are some veins which are inside the vertebral bodies, and there are no arteries like that. We call them basivertebral veins, and you can see these are these channels, yeah, which perforate the bone. They are similar to diploic veins of the skull. And they form plexuses, the internal vertebral venous plexuses, and then the external, the anterior and the posterior one. Yeah, or you can see them here. Anterior, external, anterior, internal, posterior, internal, posterior, external. And they are then connected by the homonymous veins to arteries. So they are connected to vertebral veins and azygos, hemiazygos vein and ascending lumbar vein. Yeah? So they come to the closest regional veins which match the arteries. Okay. Questions? So we have already spent 3/4 of an hour and we have not talked about the spinal cord really yet. So now we go in. Now we go in to talk about the internal structure. The internal structure consists of white and gray matter. The white matter is more superficial and it forms so-called funiculi. Yeah, and the funiculi are anterior, lateral, and posterior. Yeah, so you can see the anterior here, the lateral here, which are supplied by the anterior spinal artery, and the posterior here. Then the gray matter forms also an anterior, posterior, and the third one, which is called intermediate column. So you have then the anterior here, the posterior here, and in between is the intermediate. Because it's in between, it's called intermediate, not lateral. And a column, yeah, you can see how the column looks like. And the last structure in the midline is central canal. Yeah, the central canal, I'm sorry, the central canal is running like this down, and it's blind, it's cul-de-sac, yeah, at the level of L1, there's a termination and it does not continue. It continues up to the fourth ventricle, yeah, fourth ventricle, which is inside the brainstem. We will talk about this in the next lecture. So the internal composition is not so complicated. Now when we see it on a section, yeah, on a section, we can see again the funiculi. So this is the posterior funiculus and lateral and anterior funiculus. The gray matter, which is here white, we call on the section not columns, but horns. So this is the anterior horn. This is the intermediate column, but on section it's called lateral horn. Yeah, so lateral horn, but intermediate column. Yeah, so these terms do not match properly. And posterior horn. So some other structures which you can see and which we already know. This is the anterior median fissure. This is the posterior median groove, yeah, which is shallow. There's a continuation of pia mater inside, which we call posterior median septum. So only here and here we have communications from the left to the right. So we call them anterior and posterior wide commissure. Yes. So the left and the right parts are connected only here in the middle. These small areas, which also connects the gray matter, are called gray anterior and posterior commissures. Yeah, they are very small ones. So this is the spinal cord on the section at two-dimensional view, and here you can see the local differences. Okay, anterior horn is quite enlarged in the area of the intumescences, of the swellings, where the alpha motor neurons for upper limb, so this is brachial plexus, lumbar and lower limb, lumbar plexus and sacral plexus are visible. Yeah, so that's why these parts are enlarged and we call it intumescence. Then in the area of T8, we can see the lateral horn enlarged because it's the area where we can find sympathetic visceromotor nucleus, yeah? The intermediolateral nucleus, which is here. The same would be at the level of C2 to C4, which I have not shown here. So these are regional differences. And now let's talk about more detailed anatomy, the nuclei and the tracts. So the tracts we have organized longitudinally. Yeah, the tracts are composed of fibers and big bundles of fibers we call funiculi, the anterior, lateral, and posterior. Yeah? Horizontally, of course, some of the fibers cross. When they cross from the left to the right, like the pyramidal tract at the level of C1, we call it decussation. Yeah? So decussation is a crossing of the fibers inside the central nervous system. When it's outside, you know it as a chiasm, and the optic nerve and optic chiasm you already know. So that's a crossing of fibers outside the central nervous system. Inside, it's called a decussation. And then you have another fibers which cross from the left to the right side, and they are called commissural. And these commissural fibers all the time interconnect the same structures on the left and right side. So these are commissural fibers, and decussation fibers are like this. Yeah, from a different to different area. So this is a decussation. You just cross it and you continue. Commissures are not like that. It interconnects the same structures which are located contralaterally. Okay, so now we can start the section of the spinal cord, but before that we have a break. Yeah, how long break do you need? 6 minutes is fine. So we continue inside the gray matter, and we will talk about the nuclei, which are the most prominent structures here. It of course contains many interneurons, but the neurons where the sensory fibers terminate or where the motor fibers originate, they are clustered in nuclei. Of course, if you perform a section, the nuclei are not visible by naked eye. That's why there was a guy, and his name was Rexed, a Swedish guy Rexed, and he decided to divide the gray matter into 10 spinal laminae, or into 10 zones. Yeah? Here are the numbers and the names. When we go back, you can see that the numbers go, the number 1 is somewhere here, and then we go from dorsal to ventral. Yeah, so this is one of the division which is necessary to know. The second is that the posterior horn contains, or the posterior horn has got a shape of a head maybe. So then this is called apex, and then this is called a body. Oh, sorry, a head, caput, and then this is called a base. Or maybe here better, not body, but C, like caput, yeah? So apex, caput, and base. Apex, caput, and base of the posterior horn. So that's another division, and you can see here that we have apex, caput, and the base. And we have, of course, a cervix here. So caput and cervix. This is an old-fashioned one, yeah? So we do not use it much in clinics, but exists. So it would be nice to know this passively. Yeah, we won't examine it, but passively you can know that it's divided into these four morphological parts. But what we have to know that we have here some nuclei. Yeah, in the posterior horn we have three important nuclei. Two are here, and the third I have shown. Then in the lateral horn we have one nuclei, and in the intermediate zone, which is this, call it intermediate zone, we have another one, and then in anterior horn we have these. So we can start with these because they are the most easy. Yeah, these we call according to the position. So number 7 is central, number 6 are medial, so anteromedial and posteromedial, and number 5 are lateral, anterolateral, and posterolateral. These medial ones are for epaxial muscles. Yeah? And these lateral are for hypaxial muscles. So of course, they will be larger than these. Yeah, it's just a scheme. So the anterior horn is somatomotor. It contains alpha motor neurons and gamma motor neurons. The gamma motor neurons are not located in the number 7, in the central one. They are located just next to alpha motor neuron for the same muscle. Yeah. So alpha and gamma motor neurons. What is the difference? The alpha motor neurons, they just go to neuromuscular plate of the muscle. The gamma motor neurons, they go to neuromuscular plate of the muscle spindle. Yeah, muscle spindle is a small receptor inside each muscle. So that's the anterior horn, which is somatomotor. Then the lateral horn. The lateral horn contains so-called intermediolateral nucleus, and it's an autonomic nucleus. Yeah, and the autonomic nucleus can be sympathetic or parasympathetic. And you already know the levels. The sympathetic is CA to L3 approximately. Parasympathetic S2 to S4. Yeah. So that's the visceromotor intermediolateral nucleus. The viscerosensory intermediomedial nucleus is this one, and it's viscerosensory for the same areas as the visceromotor intermediolateral one. So this is the autonomic area. And then the most complicated is posterior horn. In posterior horn, we have 3 nuclei. This nucleus is called the substantia gelatinosa. So I can come here. It's called substantia gelatinosa of Rolando. Yeah, that's one somatosensory nucleus, and this is mainly for pain information, but for the pain information concerning slow pain. Yeah, I will talk about this a bit later. So substantia gelatinosa, yeah, it should look a bit as a jelly on a section, but on histological sections. Then we have this, which is quite big one. And it's called proper nucleus. So it's the largest nucleus of the posterior horn or posterior column. Yeah. So proper nucleus. And you can see that it also covers 2 rexate laminae. So it's big one. We will talk about these nuclei in several minutes when we will talk about the tracts, about the white matter. Then you will understand the function of the nuclei. And the last nucleus is here. It's so-called Stilling-Clark nucleus or posterior thoracic nucleus. It means it's the largest inside the thoracic area. So it's this one. Yeah, posterior thoracic nucleus of Stilling-Clark. And this nucleus serves for tracts into cerebellum. Yeah. So just to repeat, we have in the anterior horn, we have 5 nuclei which are for somatomotor fibers. Yeah. In lateral horn and adjacent intermediate zone, that means here, here, we can find intermediolateral, which is visceromotor, intermediomedial, which is viscerosensory, and partially the posterior thoracic nucleus of Stilling-Clark, which sends information, which is somatosensory, and sends information into cerebellum, yeah, to cerebellum. And then the posterior horn, and inside posterior horn we have two major nuclei, the substantia gelatinosa of Rolando and the proper nucleus. It does not mean that there are not other nuclei and groups of neurons, yes, but their knowledge is not important for physician. So then we skip all the other information, yes? Okay, question to this. Of course, you need to see the figures to read more about the nuclei and to understand the tracts, then it will make more sense. Okay, now let's talk about the tracts. In the tracts, we have descending and ascending. And you can see then that this and this are fibers of the pyramidal tract. And these fibers comes to the anterior horn. And you can see that the anterior horn has got so-called somatotopic arrangement. Somatotopic means a topography of the soma body, that medially, and I can come here, medially are neurons for epaxial muscles. So here you can see neurons for epaxial muscles. Laterally, you have neurons for hypaxial muscles. Yeah. So this figure should show you the somatotopic arrangement, that medially are the muscles closer to the axis of the body, to vertebral column, and the more laterally you go, the more distal muscles of the limbs are located. So the somatotopic organization, which is in the gray matter, will be also here in the white matter, as I'm going to show you now. So which are then the tracts here in the spinal cord? Here you can see the 3 main ones. This one is descending, and it's the pyramidal tract. And these 2 are ascending, yeah? And we call them spinothalamic, and these we call spinobulbothalamic or thalamocortical. Yeah, I'll come to them again. So here on the section you can see, of course, we have more of them. So we have number 5, which is corticospinal tract, lateral corticospinal. And we have here number 11, which is anterior corticospinal tract. These two are corticospinal tract or corticospinal fibers, and it's similar to the term pyramidal tract. Yeah. So why we call it corticospinal? As it goes from the cortex, from the area 4, to the spinal cord, to the alpha motor neurons. Why we call it pyramidal? As it passes through a pyramid of medulla oblongata. We will talk about this pyramid in the next lecture. So they can be considered here at the level of spinal cord as synonyms. Yeah, pyramidal tract or corticospinal. Why we have lateral and anterior? It splits. So it goes from the, it goes from, this is a brain, yeah, and the cortex of the brain. It goes down, crosses, and continues. So this is the first neuron. Here is the second neuron. The first neuron is area 4. Yeah. First neuron, second neuron. Area 4. The cortex can be divided into 51 or 52 areas, Brodmann areas. Yeah, we will talk about these areas then later in the cortex, but already now we can have an idea where the tract goes, and it will help you then later. So it goes from the area 4, which is a motor area. It is crossed at the level of C1, and the crossed fibers form 80%. So 80% of the fibers are crossed. Why they are crossed, we really do not know. There are several theories about why they are crossed. None of them is prevailing, so you can really skip these theories. Yeah, you just have to know that these fibers are crossed, and then it terminates at the alpha motor neuron in the anterior horn. Yeah. And what about the 20%? The 20%, they just go down and they cross at the area of the spinal cord. So finally, majority of the fibers are crossed. Yes. So this is the pyramidal or corticospinal tract. So that means this one. Yeah, this is the lateral. And you can see that the fibers are also arranged somatotopically. That means cervical are most medial, sacral fibers are most lateral. Yeah? So this we call the somatotopic arrangement or organization, and we can see the same here, yeah, both in gray matter in the anterior horn or in white matter as well. Yeah, it's organized somatotopically here. So you have the cervical, thoracic, lumbar, and sacral fibers. So that's the first tract. Yeah, we have talked about that was the anterior corticospinal and lateral corticospinal. So do we have some other descending tracts? Yes, we have. We have this, which is called a reticulospinal. It descends from reticular formation. What is reticular formation? It's within the brain stem. If you hear reticular, it means like a web, spider's web. So it's a web-shaped formation. And it means it's a cluster of nuclei and fibers, yeah? So it really looks like a web. What is the function of the reticular formation? The function is the basic life functions: breathing, heart function, vasomotor function for the vessels, then micturition, defecation, sexual function, consciousness, for example, and of course quality of movements. So not the movements itself, but the quality of the movement. So the reticular spinal fibers, if I drew them somehow here, so we can have a reticular formation here, and the fibers of the reticulospinal tract, yeah, they descend. Some of them crossed and descend, and they go to gamma motoneurons, yeah, for the muscle spindles. So reticulospinal tract supplies the gamma motoneurons, corticospinal or pyramidal tract supplies the alpha motoneurons. Okay, do we have some other descending tracts? Yes, we have, of course. So which of them? We have something which is called rubrospinal tract, yeah, number 7 here. Rubrospinal tract comes from something which is called red nucleus, nucleus ruber. So we have a red nucleus here in mesencephalon, so we will talk about this. It's crossed and it descends down and terminates here. Yeah, I'm sorry for that. I don't know how to get rid of it. Okay, I'll try it again. Crossed and descends. Yeah, and it serves for activation of the muscles, proximal muscles of the limbs. So the girdle muscles, yeah, of the pectoral girdle and pelvic girdle muscles. So it serves for the activation of the girdle muscles mainly. The corticospinal tract is mainly aimed at the distal muscles, so forearm and hands and leg and feet, yeah. So that's cerebrospinal tract. And then the last big tract is this one, which we call vestibulospinal. And what is vestibulum? Do you know what is vestibulum? Please give me the answer, so I know you are there. Entrance. Of course, do not translate it. Tell me what is vestibulum in the human body. Vestibulum is a space behind the entrance, yeah, like an introduction hall. But where is vestibulum? In the skull. In the ear, yeah, it's inside the inner ear, yeah, and it contains saccule and utricle. So it's supplied by vestibulocochlear nerve. That's why it's called vestibulocochlear, and it serves for balance. So vestibulospinal tract, which comes from vestibular nuclei. So we can have here like number 8, vestibulocochlear nerve. We have the vestibulospinal tract, which comes down. And it serves for posture muscles, yeah, which are posture muscles, muscles which keeps your posture. That means the epaxial, the deep back muscles, and for example, the gluteal muscles and quadriceps femoris muscles. Yeah, the muscles which keeps you standing, keeps your balance, keeps your posture. Yeah, so the vestibulospinal ones, which are mainly extensor, these muscles. So the vestibulospinal tract innervates these muscles. Yeah. Okay, so these are the main tracts. We will add some more tracts later, but these are the main tracts. Yeah? Questions to this? Now it's necessary only to know the name of the tract and the function in one sentence, and then the position inside the spinal cord. Okay. Okay, now let's talk about the ascending tracts. Yes. The ascending tracts has got some organization. The organization, general organization is like that. First neuron or first order neuron is all the time in spinal ganglion. Yeah? You know that in the spinal ganglion there are pseudo-unipolar neurons located, and they serve for somatosensation and visceral sensation. So for all the tracts, the first neuron is located here. Then the tract can be either synapsed in the spinal cord, or it can run up through the spinal cord to the brain stem, and it synapses there. So the second order neuron is either in the posterior horn of the spinal cord or in the brain stem, usually in medulla oblongata, but it can be in other different parts of in brain stem. Then from here, another neuron, so the third order neuron, it runs into thalamus. Okay? As a thalamus is the secretary of the cerebral cortex, so all the information except olfaction has to pass through thalamus into cerebral cortex. So it passed to thalamus, and the nuclei are called the ventrobasal nuclei. Yeah? And the nucleus which we will need is called ventral posterolateral nucleus, VPL nucleus. Yeah, you can already learn this. And then it terminates in cortex. But we have also some other tracts, not only these, so they can terminate in cerebellum as well. Some of them terminate in brainstem. As we have seen, the descending tracts originate not only in cortex, but also in reticular formation in vestibular nuclei, or in ret nucleus. What do these ascending tracts transmit? So they can transmit touch. And the touch can be then divided into a crude touch and a fine touch. The crude touch is transmitted together with the pain and heat and cold information. And another is proprioception, so the information about position of your limbs and muscles, and it's transmitted together with the fine touch. Yeah, so we have a touch, pain, heat and cold, proprioception information. So they are different informations, but they are transmitted by two major ascending tracts. Okay, which are these tracts? So one of them is so-called spinobulbothalamocortical, as it goes from the spinal cord to bulb of brainstem, which is also called medulla oblongata, as we will learn in the next lecture. So the bulb here, bulbus, means medulla oblongata, an old term, to thalamus, to the VPL nucleus, and then to cortex, to some areas. You may remember area 4, which was the motor. Sensory innervation, sensory areas are 3, 1, 2. Why they are not 1, 2, 3? As they have been defined histologically, and then later the function was related to them. So histologically they were defined in some order, and then the function come and we use the order according to the histology. So that's why we all the time say 3, 1, 2. This tract runs within posterior funiculus. So it should be called posterior funicular tract, but you can find the name posterior fascicle tract as well. You can find another name which is called lemniscal system. Why lemniscus, I will explain you in the next lecture. And you already know it, as we call its two parts, gracile and cuneate fascicle, which I showed you on the transection of the spinal cord. So there are many synonyms and you have to learn all. Yeah. So gracile and cuneate fascicle forms all together a tract of the posterior fascicle or lemniscal system or spinobulbothalamocortical tract. Complicated, but it is like that. What does it transmit? Fine touch. Yeah, fine touch, which is one important information, and proprioception. Oh, I'm sorry, I'm missing here proprioception. So these two informations comes, yeah. Proprioception, which tells you, it comes from the muscle spindles and gives you information about the tension of the muscle spindles. That means it gives you information then about the position of the muscles and related, then derived position of the limbs according to the trunk. Yeah, so it gives you a sense of position of the parts of the body. Proprioception coming from muscle spindles, and fine touch coming from tactile receptors, which are free nerve endings or many corpuscles like Vater, Pacini, Ruffini, Meissner, and these we will learn them later. And the fine sensation also comprises discrimination of 2 points, so you are able to differentiate, to discriminate, to discern 2 different points. Yeah, like when reading the Braille's alphabet for the blind people with your fingers. It serves to feel the pressure, tension, vibrations. So this is this tract. I can return to where when we can find the tract. It's this spinobulbothalamocortical tract, or gracile and cuneate fascicles all together. Yeah, and they fill the posterior funiculus. They have also somatotopic organization, yeah, as you can see here. So that's the location, and it's supplied by posterior spinal artery. Well, the other system is called Anterolateral System, because it is comprised within the anterior and lateral funiculus. And it's called spinothalamic tract. So it goes from the spinal cord, as we can see here, from the spinal cord, where is the first order neuron? From the spinal cord here, from the spinal cord, where is the second order neuron? Directly to thalamus, where is the third order neuron? Yeah, to the VPL. So spinothalamic tract comes to the VPL, and then to area 312. Well, you can see that it converges with the spinobulbothalamocortical tract in VPL and goes to the same areas of the cerebral cortex. Yeah, but it has different course during different course inside the spinal cord and brainstem. Yeah, I will explain you a bit later. What does it transmit? It transmits the rough sensation, so the crude touch. Yeah. This is the crude touch. And together with that, crude touch, it's heat and cold and a fast or acute pain. So you can imagine if you touch heating at your home, the heating is big, so crude touch, it's hot or in summer cold, and it really makes pain if it's too hot. Yeah, so you can think about like touching, heating. So fast pain, heat, cold, crude skin sensation. What about slow pain? What is a slow pain? Fast pain is you step on a pin. Slow pain is you fall during skiing, and after 3 months you still have some pain in your back. So that's the slow pain. So the function of the slow pain is more to inform you about that still there is a problem. So the slow pain has got a different tract, spinoreticular. So it terminates in a reticular formation, not in directly, this goes to thalamus. This goes to thalamus as well, so that it continues into thalamus. But the nucleus is different. It is not called VPL, it's called IL, intralaminar. Yeah, we will learn this later, don't worry. And then it goes to the area 6 and 9 in the cortex. So you can see that the function of the slow pain is different than the fast pain. Fast pain is, I step on a pin, yeah, it hurts, I have to do something. Slow pain, yeah, it's still here, it's annoying, I have to do something to get rid of this slow pain. So it goes to the areas which are motor and the areas which are in prefrontal cortex, so the thinking area and the conceptual areas. Yeah, but we will come to this later again, don't worry. Just now it is necessary to know that we have a special tract which is called spinoreticular tract. How is it with decussation? So the spinoreticular is decussated and non-decussated as well. So it's half and half. Half is decussated, half is not decussated at the level of spinal cord. Yes? So decussation is at the level of the spinal cord. Spinothalamic tract is decussated, full decussated at the level of spinal cord. But the spinobulbothalamocortical tract is decussated here in medulla oblongata. Yeah. So it's also decussated, but much farther above. Yeah. So not in spinal cord, but in brainstem. I will draw the difference in a minute, but just here to conclude that we have another tracts than these three. We have spinocerebellar tracts, anterior and posterior, and they bring all the information we have talked here. So they are like collaterals to all these. So they take proprioception, fine touch, crude touch, fast pain, slow pain into cerebellum. Cerebellum is quite big, as you know. And the function of cerebellum is to compare all the information which comes with some of the knowledge and experience you have. And if something changes, you have to react on that. So you can think about, I'm walking outside and I walk on a pavement. Then I change it and go on a grass. So I have to step in a different way. Then I go from grass onto a stones. So you have to keep the balance more. Then I start to climb. Then you have to react to this. So the cerebellum receives all this changing information about the changing environment and helps you to accommodate to the changing states. That's why we have the spinocerebellar tracts. Yeah, it gives the same information, but it takes they take this information or transmit into cerebellum, not into thalamus and cerebral cortex. Okay, so when I'll come here back, you can see the spinothalamic tract here, yeah, anterior and lateral, and you can see that it's also somatotopically organized, cervical medially, sacral laterally. So why these two are organized like that and spinobulbothalamo-cortical tract is opposite? Because these two are already crossed and this one is uncrossed. Yeah, so that's why it's opposite. It's like a mirror. So we have talked about these ascending, and now I'll show you these were descending, and I'll show you the ascending ones. So we have talked about the posterior fascicles, or this gracile and cuneate, yeah, gracile and cuneate fascicles, or we call it spinobulbothalamo-cortical. So you can see the first neuron is here in the spinal ganglion, and then it goes up, ascends, and where does it accusate? In medulla oblongata. So it goes like this, to the spinal cord, up to the medulla oblongata, where it's synapsed. Yeah, synapsed is drawn like this. Then it's crossed. And it goes to thalamus. Yeah, that's the VPL nucleus. And then it goes from VPL to area 312. You can use, for example, Memorix. At the end of Memorix, there are, at the end of the chapter of CNS in Memorix, there are the tracts explained and drawn. So you can go and see how the tracts run. You can read more about them, yeah, just to fix the name and the function, yeah. And I will return to them, and they will be like a thread running through all the lectures, and you will use them as a support that you already know some of the structures, yeah. So this is the cuneate and gracile, or the areas of or these spinobulbothalamo-cortical tract. Why we have two fascicles? The somatotopic organization is like this. So sacral and lumbar. So in the sacral and lumbar area, you have only the gracile fascicle. And in thoracic and cervical, yeah, thoracic and cervical, we have already the cuneate one. Okay. Then the other, for example, the spinothalamic, anterior and lateral spinothalamic, yeah, for fast pain, crude touch, hot and cold, which we find here, yeah, this one and this one. So it also enters spinal cord, but then it's synapsed, and it's synapsed in the proper nucleus. So I'll come here, it's synapsed here, yeah, in proper nucleus. So it comes here and synapsed here. So it's synapsed in proper nucleus. So we can write it here maybe, yeah, proper nucleus. And then it's crossed and ascends to the VPL and to 312. So it comes to the same area in the cortex by a different way. And when we have a transection here, we will have a different symptoms, and I will explain this. So that's very important, yeah? Then for the slow pain, we have the spino-reticular tract. So the spino-reticular tract is just close to it, yeah? Here, number 15. So it also comes here, and it's also synapsed, and it's synapsed in substantia gelatinosa mainly. Yeah, so it's synapsed in substantia gelatinosa, which is in here, substantia gelatinosa. So now you understand why you should know these two nuclei, yeah? So it's synapsed, and it's either crossed and descends up to reticular formation, or it ascends ipsilaterally. Yeah, so there are fibers which are crossed and fibers which are not crossed. And then it goes into thalamus to intralaminar nuclei. Yeah, and then it goes to area 6 and 9. So you can see that the slow pain has different tasks. One of them is to activate reticular formation, and one is to go to thalamus and cortex. Well, and the last ones are the cerebral, are the spinocerebellar, anterior and posterior, yeah? Anterior and posterior spinocerebellar. So we can see them here. They are on the side, number 3 and 4. Yeah, so anterior and posterior cerebral. And they go up to cerebellum. So where they are synapsed? They are synapsed in posterior thoracic nucleus of Stilling-Clark. So when I'll come here back, you can see the posterior thoracic nucleus of Stilling-Clark. On a figure it was here. Yeah, posterior thoracic nucleus of Stilling-Clark. So it's synapsed. And it goes up and to cerebellum. Yeah. That's the posterior tract. The anterior tract is decussated, goes up, it's decussated and goes back. I don't complicate it here now. Yeah, we will talk about this a bit later. Or I can complicate it. This is the posterior one, and the anterior one is decussated, goes up, it's decussated, and goes here. That's the anterior one. Yeah. So what is then the final? Is that it stays on the same side, even it goes this complicated way. So these are the ascending tracts. Questions? I really recommend you that all the tracts we have talked now, that means 4 ascending and 4 descending tracts, read the tracts in the summary of the tracts in Memoryx, so you will understand how they run, what they transmit. And then you can come back to this transaction and you can learn where they are located. Yeah, and we will need them, so do this please at first, so you will then understand why the tracts are mentioned in the different levels and what is their function. So you can give me questions. We have some more things to do, but I can now answer some of the questions. If there are no questions, what we have to do are regional differences. And these regional differences concern the gray matter, and I think it won't be a problem for you. The question in Memoryx still, where should we study for CNS1 test? What does means in Memoryx still, where should we study for? I don't understand the question. Please, Moses, write it again. The regional differences. Yeah, phrenic nerve. You know, phrenic nerves comes from segments C3 to C5. It's a plus diaphragm. It's for our life important. If you have spinal cord injury above C3 or C4, then you are not able to breathe. Yeah, and there should be an artificial breathing, ventilation used. Yeah, so this is a nucleus which you have to know. From the cranial nerves, you know that the accessory nerve has got a spinal root, and the spinal root comes from quite large area, from segments C1 to C6. So there's a nucleus for the accessory nerve, of course. And from the cranial nerves, you know that the trigeminal nerve has got 4 nuclei. One of them is called spinal nucleus, as we can find it within the medulla oblongata and spinal cord, down to the level of C1 to C2. Yeah. Well, within the cervicospinal area, there is no lateral horn because the intermediolateral nucleus, sympathetic, starts at the level of C8. So from C1 to C8, in the lateral horn or intermediolateral column, there should be some structure, and the structure is extension of the reticular formation from the brainstem. Yeah. And as C8 to L3 is sympathetic, parasympathetic, intermediolateral nucleus is S2, S4, and S2, S4 are also roots of pudendal nerve. So the parasympathetic fibers travel together with the pudendal nerve, and the nucleus is called Onuf's nucleus. So all of them, you know, you just have to realize that they are part of spinal cord as well. So we have talked about all these, and here is the review of the descending tracts for you. I will just summarize it. We have talked about the pyramidal or corticospinal tract, and we have talked about the vestibulospinal, reticulospinal, and cerebrospinal. And the pyramidal tract concerns the voluntary movements. Yeah. The involuntary movements are mediated by the other tracts. And as they are not transmitted via the pyramidal tract, we call them extrapyramidal. So in neurology, when you have an extrapyramidal symptom, it's a symptom of lesion of non-pyramidal tracts, of non-voluntary one, yeah, one of these. So the term extrapyramidal system means an involuntary movement tracts. Okay. So some neurological terms which you have to understand. So this concerns the pyramidal tract. Yeah? The pyramidal tract has got 2 neurons. One is in the cerebral cortex in area 4. The second is the alpha motor neuron in spinal cord. Yeah? In the anterior horn. This is what you know. So the first order neuron is in the area 4. The second order neuron is alpha motor neuron in anterior horn. Yeah. So, and it's decussated, yeah, at the level of C1. That's the decussation of the pyramidal tract. So we have the term a paresis and a plegia. Paresis is an incomplete paralysis or palsy. Yeah, these are synonyms, palsy or paralysis. Plegia is a complete palsy or paralysis. So you have to differentiate these two. And then we come to the number of the limbs. If we have problems at the level above the level of C5, we have all 4 limbs. So we have quadruparesis or quadriplegia. If we have problems only in lower limbs, we call it paraplegia or paraparesis. And when we have problems on one side of the body, either left or right, so one upper limb and one lower limb, we call it hemiplegia or hemiparesis. Yeah? If I have a problem in the pyramidal tract, we call it central or spastic, because the patient has got spasms. If you have problems in the peripheral nerve itself, the spinal nerve or cranial nerve, we call it peripheral or flaccid, because there is no spasm, there are no spasms. Yeah? So these are just the terms to understand. If you have any questions, of course you can ask. And now you have here the example of the spinal cord lesions. So here at the number A, what you can see, a full transection. Full transection. So what it means when you have a full transection. So you have this. We have paraplegia, yeah, no movements of the lower limbs, paraparesis, paraplegia. Then you have no sensation, no fine touch, no crude touch, no sensation. We call it anesthesia, yeah, anesthesia. You know the term anesthesia, that you would like to have patient not feeling anything, but of course anesthesia means that you do not feel touch. If you do not feel pain, it's called analgesia. So this patient has got paraplegia, no movements, anesthesia, no feelings, analgesia, no pain, and of course, no proprioception. So no information about where are my limbs. You can find this only using your eyes, yeah? Only the visual control can tell you where the lower limbs are. So that's quite easy. But now, what about this? Yeah, number 3, it's a syndrome of anterior spinal artery. When the anterior spinal artery is closed, what happens? I told you that the anterior spinal artery supplies anterior 2/3. So the only information which is surviving is the information transmitted by the posterior 1/3. Tell me, which kind of information is it? Which modality is it? Not the name of the tract. Tell me which kind of modality the patient will retain. Yeah? Of course, he will lose movements. Yeah, so he will be paraplegic. Now I can see if you have understood what I have to try. Fine touch, perfect. Fine touch. Simran, perfect. Fine touch. And this spinobulbothalamo-cortical tract, or gracilis and cuneate tract, or posterior fascicle tract, or lemniscal system carries fine touch and not deep back muscles. Deep back muscles are supplied by pyramidal tract, and pyramidal tract descends here. Yeah? So pyramidal tract is not working. Fine touch and proprioception mirai, perfect. Perfect. Pain is wrong, as pain travels in spinothalamic, lateral and anterior, which is here. Yeah. The answer is proprioception and fine touch via the spinobulbothalamo-cortical tract. Yeah. I hope you understand this. So then closure of anterior spinal artery is quite severe for the patient. And then we have this model, spinal hemisyndrome. Yeah, it's used in physiology as a model to understand the decussations of the fibril tracts. But it can happen, of course, as a lesion. Yeah, and it has been first done by Brown and Sekar. So it's called Brown-Sekar syndrome or spinal hemisyndrome. So what happens if you transect it here? Which are the problems? Yeah, the problems come from sorry, not well drawn. Now you have to understand which tracts are decussated and where. So the descending motor tracts, the pyramidal tract is decussated of the level of C1. Yeah. So that's the pyramidal tract. So when we say that the problem is here on the left side, this is the left side, as you can see in the patient, the left side. So the patient has no movements in the left side. Yeah. So he's got a hemiplegia, or if it would be upper here, it would be closer. You have problems in the upper limb. Here will be problems in the lower limb only. Yeah. Okay. So that's the problem with the movements. There will be a plegia of the lower limb. What about the problem with the sensation? Under tract, which is going like this, here it's synapsed, here it's crossed and goes up, is the spino bulbo thalamo cortical. So fine touch and proprioception. So on the same side, the patient will lose a fine touch from the lower limb and a sensation of the position, so proprioception. But how is it with the pain? The pain comes here, it's synapsed, it's crossed at the spinal level and goes up. So the patient has good pain feelings. Yeah, he feels pain from this limb, but does not feel pain from the other limb. Yeah. If the problem is, and I now show where is the level. Yeah, the level is here. Do you understand this? That the patient has in the left limb, when the transection is on the left side, so on the same ipsilateral side, there is no movements, so paralysis, problems of the pyramidal tract, no fine touch, no proprioception, problems of the spinobulbothalamocortical tract, but feeling of the pain is there, yeah, as the tract is decussated. But on the opposite side, there is no feeling of pain, cold, and heat, and crude touch because of the spinothalamic tract lesion. Yeah. So ipsilateral problem with the proprioception, fine touch, and with the movements, and contralateral problems with acute pain or fast pain, heat and cold. You understand this, please? Oh, I don't have it here written. I just have to explain it. Okay, it seems that you understand it. And to conclude, we have 3 syndromes. Yeah, one is the syndrome of the Cauda equina. So when we have problems below level of L2, yeah, usually herniation of the discs, and herniation of the disc usually occur at the level of L4, L5 as one. So when there is a herniation of the disc, it usually affects some of the roots, yeah? Not all the roots, but some of the roots. That's why it's asymmetrical. These are the roots of the spinal nerve, so it's a peripheral or flaccid palsy. So there's a muscle atrophy, and there are no reflexes, no muscle tone, yeah? Of course, it's not only problem of the somatomotor, but the problem of somatosensory fibers. That means no pain, so and no touch, so anesthesia and analgesia, and usually not no, but reduced or missing. Yeah, it depends how the herniation is severe. But what is important? It's asymmetrical. Yeah, and there can be problems with the parasympathetic innervation, which comes from level S2, S4 via pudendal nerve. So problems with defecation and urination, yeah, retention of both these fluids. And of course, it supplies the sexual organ, so sexual dysfunctions. Yeah? So that's one. Problems with the Cauda equina. Cauda equina syndrome. If we go a bit up, if we come up to the level of L1, where we have the termination of the spinal cord, which we called Conus Medullaris, yeah? Segments S3 to S5. Segments S3 to S5 do not supply lower limb, as the lower limb is supplied by sacral plexus, and sacral plexus has got segments L4 to S4, but level S2 to S4 is only pudendal nerve, yeah, only pudendal nerve. So it means that no problems with the lower limb will be there. There are some problems with the short flexors of toes, but they are very discrete. So that's not, that's an important information for experienced neurologists, not for you. Yeah. So the problems will be in the area of pudendal nerve. So the problems will be sphincter problems. Yeah. Again, urine retention, stool problems, sexual problems, and problems with the skin perianally, perigenitally. Yeah. And it will be symmetrical. Yeah. This is important. It is symmetrical. And the cause is not usually herniation, but it's an expansion process. Expansion process can be bleeding, tumor. And then the level above, another 3 segments above, which we called epicone or spinal epiconus. Yeah. So it's the level above, so vertebra T12 to L1. It's L5 to S2. Yeah. So it's sciatic nerve. It can be identical to radicular lesion. Yeah, that means to the problems with the roots of the spinal nerves. But when it's epiconus, it's symmetrical. And you can see that what does the sciatic nerve innervates mainly are muscles of the ventral and dorsal side of a leg. So extensors and flexors of the foot. Yeah. And muscles on the posterior aspect of the thigh. So problems of the flexion of the leg. And of course, anesthesia, analgesia on the involved areas, which is posterior side of the thigh, posterior cutaneous nerve of the thigh, posterior side of leg, sural nerve, and of course foot. Yeah, and again autonomic and sexual functions. Yeah, and again an expansion process, bleeding or tumor. So it is very important to differentiate the levels of injury, and then the symptoms can be very different. And according to the these symptoms, you can find the diagnosis, and then you just apply CT or MRI. And to help you to understand it, we have here some case reports, yeah, which you have to solve. So you have a young female patient, and she comes with a severe back pain, yeah, and problems with spinal nerves on the left lower limb, yeah, which then we call in neurology radiculopathy, yeah, problems with the roots of spinal nerves. And you can see it's on the left side, so it's asymmetrical, and it's worsen, and she's got problems with the urine continence. So, according to this, which part of the vertebral column would you examine? So please write me the answer. Which part would you examine? And then I'm going to show you how it looks like. So you will examine the sacral vertebral column. So if you examine the sacral vertebral column, you will examine here the Cauda equina. But you have to examine the level where you have the roots coming from L5S2. And that's the area of the first lumbar vertebra. Yeah. So do not forget the Schiphol's rule, which tells you which segments of the spinal cord are at which level of the vertebral column. Yeah. So if you examine sacral, you don't find the problem. If you examine it here, you can see this. It's an expansion process, and then based on histology, it was found that it's a lipoma, yeah, coming from the adipose tissue, which can be found also in the epidural space. So this is L1, yeah. Okay, case report 2. An old female patient with, again, fastly growing problems, but the problems are paraplegia, paraplegia, and complete anesthesia and analgesia of lower half of the body. And she's got a scar on the abdomen, and she said there was an operation for the abdominal aorta aneurysm. So my question is, which tracts are impaired? How large is spinal cord lesion on horizontal section? And what could be the cause of sudden paraplegia? There's a question, is it possible to sense this lesion on physical examination? You ask to the Rasam, you ask the first case report? Yeah, you are able to find out the level. Yeah, you are able to find out the level, and you can think what it is, but you do not know if the expansion process is a bleeding or a tumor, and which kind of tumor. That's why you apply the MRI. But yes, you can. That's why we have learned it. That you find out that you can distinguish the level of the problem. Yeah, the level of the in the spinal cord and vertebral column. So for this case reports, what is the cause of the sudden paraplegia? What happened here to this patient? Why she's got sudden paraplegia, anesthesia? Ischemia of spinal cord, great radicular artery. Katarina, perfect. Yes, yes. How large is the spinal cord lesion on horizontal section? Complete anesthesia and paraplegia. How large is the lesion on horizontal section? Is it full, or is it just one quarter, 1/3, 1/2, anterior half, posterior half, medial, lateral? Anterior 2/3 would be it. So now we can connect it with the which tracts are impaired. Yeah, for paraplegia, if the question is paraplegia, which tracts is impaired for paraplegia? Which tracts is impaired? Which tracts is interrupted? Connected with paraplegia? No answer. No one is bold to give me the answer. Okay, paraplegia is motor. So which tract is it? It's descending, motor. It's pyramidal tract, of course. Yeah, it's pyramidal tract. Complete anesthesia is which tract? Complete anesthesia, that means fine touch, crude touch. These are both tracts, the spino-bulbo-thalamocortical in the posterior fascicles and spinothalamic in the anterior and lateral. So the answer is it's full on horizontal section because you have loss of motor function, loss of sensory function. Yeah. So if we look here, how the examination looks like, we have here ischemia, which is visible at the level of the cone. Yeah. But there was another ischemia at the level of T5. But for all the symptoms was important this ischemia at the level of the conus medullaris. Yeah, the ischemia are these white areas of the MRI. You will learn this then later in imaging methods. And if you then look at the previous CTs, you will find this aneurysm of aorta and even the problems with the kidney. So the aneurysm of aorta closed the renal artery and the kidney here was ischemic. Okay, any questions? The question, why do some people experience phantom limb syndrome? Phantom limb syndrome appears in a transection of the nerves. If you have to cut it, the nerves are cut, but still the end of the nerves, they are irritated. And the patient feels these irritations and his brain still thinks that the limb is there. Yeah. The question is CSF only extracted by lumbar puncture and not from any other region? In small kids, you can perform suboccipital puncture, yeah, which goes into the great cerebromedullary cistern, but it is not performed very often. But so lumbar puncture is the prevailing, and we can say the only method which is used in adults.